Hey everyone, this is Jun and Alex, and our presentation is on a complex ankle injury. Our case was on a 12-year-old male that injured their left ankle playing rugby. The patient presented to the emergency department with substantial soft tissue swelling, localized pain, and an inability to weight bear. Our initial thought is that rugby is quite a contact-heavy sport, so it's likely the injury would fall under the trauma category. Severity of damage would influence our course of action. Common ankle injuries include sprains, fractures, dislocations, and avulsions. Possible mechanisms of injury could be self-sustained, such as tripping while running, or externally sustained, such as from a direct blow from a tackle. We'd consider not just the bones, but also the ligaments, muscles, tendons, soft tissue, and neurovascular structures. Some complications are internal bleeding, nerve pathologies, or torn ligaments and tendons. The ankle joint is made of three bones, the tibia, fibula, and talus. The ankle is a hinge synovial joint consisting of the talar facet and medial malleolus of the tibia, the lateral malleolus of the fibula, and the trochlea of the talus. The main ligaments of the joint capsule are the MCL on the medial side and the LCL on the lateral side. There's also a fibrous syndesmosis that links the tib and fib. Muscles and tendons involved in the ankle are responsible for dorsiflexion, plantarflexion, inversion, and eversion. Surrounding fat pads and neurovascular structures are also important. The tibial and fibular arteries and nerves being key structures. First step, in the radiology department, the course of action will be based on the Ottawa rules, following brief patient screening and triage. Ankle x-rays require pain to be present at either malleoli and either 1, an inability to weight bear, or 2, bone tenderness at either malleoli. The X-ray series consists of the DP, Maltese, and lateral views. If a fracture or syndesmotic diastasis is detected, a CT or MRI scan will be done accordingly for further evaluation, or both. Moving on to analysis of examinations. Firstly, no X-rays were provided in our case study. Possible reasons could be patient confidentiality or simply due to the nature of our assignment itself. Although X-rays are generally the go-to, the severity of the case may be a factor. Severe ankle fractures with no palpable pulse at the ankle may condone an immediate CT scan due to suspected vascular ischemic damage or transected arteries which are life-threatening. Signs of obvious fracture and high perceived pain from the patient may have condoned an immediate CT scan that superseded X-rays for theatre intervention. CT may be preferred over MRI due to cost and time efficiency, as it can also demonstrate soft tissue structures. CT is a computerized X-ray imaging technique to produce internal images of the body. A quick and cheap 3D model is produced showing bone and soft tissue, which can be broken down into 3 planes. Actual images go from the feet to the head. Corona goes from the front to back. Sagittal goes from side to side. The left and right side is always from the patient's perspective. Images are based on radio density measured in Hounsfield units. Air is black as it's radiolucent, allowing X-rays to pass through easily. Bone is white as it's radiodense, blocking X-rays. Soft tissues are shades of gray. The general order of shades going from black to white are air, fat, fluid, soft tissue, bone, metals, and contrasts. Windowing allows better differentiation by highlighting different structures of interest. Window level is the midpoint of the range, which is set at the tissue. Window width is the set range of Hounsfield units displayed. In our image, you will see soft tissue windowing and thin slices. Soft tissue window focuses on soft tissues and compresses the grayscale, making lungs appear black and bones white. Thin slices provide more images or more detail, but have more noise. Moving on to analyzing the anatomy and pathology present. Our findings were as follows. A comminuted oblique fracture and epiphyseal plate fracture of the distal tip, an avulsion and transverse fracture of the medial malleoli, soft tissue swelling, and bone bleed. Here are the CT views. Starting with the corona view, going from front to the back, here's what we see. Key features are a transverse fracture and epiphyseal plate fracture, an avulsion fracture, and an oblique fracture continuing to the diaphysis. Here's a sagittal view going from left to right. You can see the oblique fracture, the epiphyseal plate fracture, the transverse fracture, and soft tissue swelling. Next is the actual view going from top to bottom. You can see the tip to the bottom of the oblique fracture, the avulsion fracture, the epiphyseal plate fracture, and the transverse fracture. A thin slice and soft tissue windowing is shown. The thin slice shows more detail, but more noise compared to the thick slice. And the windowing view shows more soft tissue differentiation. And also, a key notable feature is this very noticeable bone bleed. Finally, here's a 3D reconstruction of it all put together. Starting from the front, we see the obvious epiphyseal plate fracture. Going posteriorly, we see the extent of the oblique fracture and the avulsed medial tibia. Coming back around, we see the transverse fracture of the medial malleolus.
From our CT scans and 3D reconstruction, and as Jin described, we can see there is a fracture beginning on the distal posterior surface of the tibia, mediolateral in orientation, and widening the more distal it travels obliquely down to the growth plate. After crossing the growth plate, it changes orientation slightly to be more anteroposterior through the epiphysis and exiting intra-articularly. When describing fractures involving growth plates, they can be classified using the Salter-Harris classification system. This classification depends on the positioning around or involvement of the growth plate. As this fracture comes down through the metaphysis, crosses the physis or growth plate, and through the epiphysis as well, it is classified as a Salter-Harris 4 fracture of the distal tibia. There is also likely a avulsion fracture of the medial malleolus. This is where the ligaments attaching to the medial malleolus have been put under extreme stress, causing them to pull off a chunk of bone from the tibia, likely due to an unnatural and forceful eversion of the foot. We also identified a bright radio-opaque nodule in the calcaneus. It is most likely this is a bone island or enostenose, which is a benign sclerotic lesion within a bone. This could be due to a condition called osteopoikilosis, which develops during childhood and is asymptomatic. It is a genetic disorder that leads to many of these bone islands. However, due to its lack of symptoms or any harmful effects, it is often an incidental finding and not relevant to the patient's health. If the patient were to receive more imaging at an older age, the presence of more bone islands would confirm this, or prove that it is only a single bone island growth. However, it is also possible this is an osteoid ostoma, another benign condition, however this time due to a tumor. This condition by comparison has pain associated, however can be treated with non-steroidal anti-inflammatories and more commonly occurs in the long bones rather than the calcaneus, making a single bone island more likely. As this is a Salter-Harris 4 fracture, the treatment options are more complex than simpler fractures that don't involve or cross the growth plate, as lack of treatment as well as treatment itself could cause growth abnormalities. This is most likely why a CT scan was necessary for this patient to determine the level of displacement or distance away from the rest of the bone the fractured piece of bone is. If this displacement is measured to be less than 2 millimeters, then in nearly all cases, the only treatment necessary is closed reduction or manipulation of the fractured bone into the correct position over the fracture site and application of a cast. If displacement is greater than 2 millimeters, then surgical intervention may be required, with metalware such as screws, brackets, or K-wires to fix the avulsion fracture back to the medial malleolus and the posterior fracture of the tibia back to the bone and hold the epiphysis back together. There are important considerations for both of these methods. If the fracture site isn't reduced adequately in the closed reduction, then the bone may not reattach properly, and the tibia may not grow as it should. However, there is also potential for the screws and brackets in an open reduction internal fixation to limit or inhibit bone growth as well. This is generally why a conservative approach is taken with pediatric cases, as surgeons do not wish to cause harm to the bone long term when trying to fix it in the short term with metal, preferring instead for closed reduction unless absolutely necessary. When looking at our patient's fracture, there is some displacement. However, it appears varied, with it being near non-existent in places, with some areas in the same slice also appearing greater than 2 millimeters apart, where blood is exiting the fracture site. It is also possible once the bone vasculature clots off and the blood is drained away, the pressure within the bone would decrease, thereby reducing displacement and allowing for closed reduction of the fracture site. This, combined with the conservative approach being preferred for juveniles, makes it our recommendation that the patient undergo closed reduction of the fracture site and an above-knee cast to hold the fracture in place and to discourage weight bearing or use of the leg while healing. In this case study, we have followed a case of a child being injured playing sport and their likely path through the healthcare system, with a focus on imaging. While the presentation of a broken ankle may appear simple, this case study highlights the potential complexities of fractures involving joints and the lifelong implications for the patient when it comes to choices of their treatment. CT imaging plays a major role in assisting professionals to determine the best course of action for their patients, as was the case for this patient, and as such, it is an invaluable tool.